Faith is just good afternoon, everyone. We're just going to wait a few seconds for folks to join us, and then we will get started. All right. Well, hi, everyone. Thank you for joining us today for this important discussion on the future of chronic disease prevention and management in Ontario. I'm Jason Field. I'm President and CEO of Life Science Ontario, and I'm pleased to be your moderator for today's event. Just before we get too far, I want to acknowledge that today I'm coming to you from the territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Ontario is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties, signed with multiple Mississaugas and Chippewa bands. Wherever you are today, I hope that you take a moment to reflect and acknowledge on the stewards of the land that you live and work on. So today we're here at a pivotal moment, one that calls not only for reflection but action. Chronic disease such as diabetes, heart disease, COPD, and others are no longer isolated health issues. They are system-wide disruptors, quietly but steadily overwhelming our health infrastructure, limiting the quality of life for millions and driving unsustainable costs across the sector. In 2013, the Ontario legislature passed Motion 45. This was a unanimous call for the government to develop a comprehensive framework to prevent, manage chronic disease in this province. That motion was more than symbolic. It was a recognition by all parties that our current trajectory is unsustainable and that we must take a fundamentally different approach. In 2020, 1.8 million Ontarians were living with a major illness, a number projected to rise to 3.1 million by 2040, a 72% increase. And these figures are not just numbers. They represent parents, children, neighbors, and coworkers, people whose lives are being shaped by conditions that we have the tools to prevent or detect earlier and manage more effectively if we act strategically and collaboratively. And if we fail to act, the consequences will be severe. Quality of life for those living with conditions will decline. Wait times will grow, costs will climb, and the burden on our hospitals, primary care providers, and caregivers will deepen. Without an upstream shift towards prevention, early intervention, and integrated care, the sustainability of our health system is at risk. And that's why LSO, in partnership with Diabetes Canada, the Health Charities Coalition of Canada, has worked to release this vision paper titled Going Upstream Towards an Ontario Chronic Disease Strategy. This paper offers not just a diagnosis of the problem, but some actionable steps starting with diabetes and extending to a broader strategy that we envision as coordinated, patient-centered, and rooted in prevention and early intervention. Our panel today brings together leaders from across the health system who will share their insights on what's needed now to build a healthier future for this province. We hope this conversation serves as a catalyst for action because Motion 45 did give us a mandate. The data gives us urgency. And now, with the ideas on the table, the question is, will we go upstream before the current pulls us further downstream? So with that, I would like to take a moment to show some pre-recorded remarks from a very special guest, the Honorable Minister Sylvia Jones, who's the Minister of Health and Deputy Premier to Ontario. Please roll the video.
Hello, everyone. I'm Sylvia Jones, Ontario's Deputy Premier and Minister of Health. Thank you to Life Sciences Ontario for hosting today's webinar and to Diabetes Canada and the Health Charities Coalition of Canada for your leadership on this important initiative. I'd also like to extend my appreciation to everyone in the life sciences sector. Your work is vital, not only in advancing medical treatments, but also in driving innovation, strengthening our economy, and improving lives across Ontario. Today's event is a powerful reflection of that dedication. More than 1 in every 7 Ontarians has been diagnosed with diabetes, the most prevalent chronic condition in Ontario. And by 2034, it is estimated that 2.3 million Ontarians will be living with diabetes. Our government understands the importance of working alongside the life sciences sector to address challenges facing our healthcare system, including chronic disease. Through Ontario's life sciences strategy, we are positioning our province as a global leader in health innovation. A key part of this strategy is the Health Innovation Pathway, which brings together clinical, supply chain, and economic development strengths across Ontario to accelerate the adoption of new technologies and significantly enhance patient care. These initiatives support today's goal of working together to find new ways to improve health and tackle chronic diseases in Ontario. Together, we can help more Ontarians living longer, healthier lives. Thank you again for your leadership and your partnership. I wish you a successful webinar. Stay well.
A very special thank you to Minister Jones for providing those remarks and for all of her support and her government support to chronic disease patients across Ontario. So now it's my pleasure to introduce our panelists. Kimberly Hansen is the CEO of Health Partners. Connie Cote is the CEO of Health Charities Coalition of Canada and a member of our task force for this project. Glenn Thibault is Executive Director, Government Affairs and Policy with Diabetes Canada, also a task force member for this project. And Dr. Sasha Bhatia is the Executive Vice President, Primary and Community-Based Care for Ontario Health. We're going to start off with each of our panelists taking 5 minutes to sort of present their initial thoughts, and then we'll go into a Q&A session. So I'm going to turn it over to Kimberly to kick us off.
Good morning, Jason. Thanks so much. I'm really proud to be here, bringing, I hope, a couple of different perspectives. One is as the lead of Health Partners, which is a collective of 20 national health charities that collaborate to support people affected by a vast range of chronic and acute medical conditions, from heart disease and stroke to cancer to mental health challenges to rarer conditions like blood disorders or neuromuscular conditions. Health Partners members do tremendous collective work to reduce and address the burden of chronic diseases on people in Canada, offering programs and services to tens of millions of people in Canada each year and funding hundreds of millions of dollars in critical health research across our country. Collectively, we amplify the voices of hundreds and thousands of people with lived experience that must inform our work. I'm also bringing the perspective of someone who was involved in shaping the National Diabetes Framework and contributing a bit to influencing the Ontario government to embrace the chronic disease strategy. I care deeply about this conversation because it is both personal and because it affects every single person in our province. It is personal because I am a person with 30 years experience living with this disease, diabetes, and its complications. And every person I knew who had this disease when I was diagnosed has since passed from its complications. It affects every single person in Ontario because millions live with a diagnosis of diabetes or prediabetes, and millions more who have those conditions don't yet know it. And every single one of us knows and loves someone touched by this or another chronic disease. There is so much that is being done, but with the prevalence of diabetes having more than doubled since the turn of the century, and Jason talked about the projection forward, there is still so much more that needs to be done. Diabetes matters to a conversation on chronic disease because every single thing we would do to prevent or delay the development of diabetes also helps to prevent or delay the development of many other chronic diseases. So we might think of diabetes for the purposes of our discussion today as one use case of a chronic disease strategy. Huge thanks to the team at LSO for convening this conversation. I'm so pleased to be part of a discussion of what that strategy could look like. Thank you.
Thanks, Kim. And Connie, we're going to go to you next.
Thanks, Jason. And my name is Connie Cote, and I'm the CEO of the Health Charities Coalition of Canada. Our coalition is a coalition of health charities whose mission is to lead collective action on health advocacy, policy, and investment in health research to benefit patients living in Canada. I want to begin my portion by really extending my thanks to LSO for really bringing us together and giving us this opportunity to really shed some light on what is happening in chronic disease in Ontario. And as Kim said, really taking an opportunity to look at how we can utilize diabetes as our test case and our platform to be able to elevate it to other chronic diseases. As you know, Jason, and you've mentioned this in your introduction, that right now in Ontario, almost 3/4 of Canadians who are between the ages of 65 and older are living with a chronic disease. We know from a recent study that was delivered in October 2024 from a collaboration between the Ontario Hospital Association and the Dalla Lana School of Public Health that the projections going into 2040 is that we'll have 3.1 million Canadians, adults in Ontario, living with a chronic illness. These numbers are outstanding and they continue to grow. These projections are huge in comparison to the numbers in 2002, which was just under a million. So the numbers are tripling. And this is something that we need to take action on now. And so this is why we came together as a community across many different stakeholders to really say, what can we do? How can we really address some of these growing concerns? And so as the title of our paper suggests, we're looking upstream and looking at how we can address chronic disease early in their progression and help prevent further issues and prevent overall health and improve overall health. Our approach was really to make some initial recommendations on 3 different areas. So we looked at how can we prevent the illness from actually developing? How can we mitigate some of those illnesses? And how can we help individuals who are living with the illness manage their chronic disease, starting with that initial focus on diabetes? Part of our overarching strategy is to lessen the incidence and prevalence of the diseases that can be prevented by combining both making systemic changes and structural changes to make that fundamental difference that we really want to see on how we deliver care for those who are living with chronic illness. So our paper highlighted several different recommendations. And what's really incredible is they're not huge shifting changes. They're not things that are unattainable. And so as I start talking about some of these, we're talking about really ensuring that individuals are able to reach out to people to find out how can I prevent, what can I do as an individual to make changes so that I can help prevent chronic disease in my life and in my family's lives. So making sure that people have access to allied health professionals, for example, so that people know where to turn and they have access to evidence-based information. Things such as adapting or creating new data collection systems so that we have an idea of what the projections might look like and know that we have really good data so to help guide us as we move to the future. Embracing innovation and technology. There's so many people who don't have access to care because they may live in remote areas. So ensuring that we're utilizing to the best of our ability these new innovations. One thing that we hear, and I know Kim talked a little bit about, the voice of patients, and that's certainly an area that we both collaborate in all the time. One thing we hear all the time from the communities that we work with is that they want consistent pathways for care. So we need some stability in the system. People need to know where they can go to get their support and be able to access consistent care. So those are some of the recommendations and key actions that have been outlined within the paper. There are 10 recommendations in all. they're really practical recommendations. And so I really encourage people to, take a deep dive, look at some of those recommendations that are highlighted, as I said, in those three in terms of prevention, mitigating, and managing disease. Um, but each of these recommendations really forms a building block that will help to prevent, mitigate, and manage better chronic disease in our province. And I'm sure we'll have lots more conversation as we go through this, but I will turn it back to you, Jason, for now, and look forward to continued dialogue on this.
Thank you so much, Connie, and appreciate all of your help in pulling this together. We're going to go next to Glenn Tebow. Glenn is coming to us from, what is it, Gate 23 in the Ottawa airport,
Yeah,
Glenn?
yes,
So,
Gate 23. Hopefully, I've found the quietest part of the airport. I've had one of those plane, trains, and automobile days where delays turn to a flight movement, and sketchy Wi-Fi here at the airport has me off camera, unfortunately, because the angle. I don't think anyone would need to see that, but otherwise, I'm just looking forward to this conversation, and happy I'm still able to be part of this. So thanks, Jason. And I really am looking forward to the dialogue on this, because truly we are gathered, I think, at a critical moment for Ontario's healthcare system. And it's one I don't think that is, not just defined by strain, but I think the opportunity to transform how we care for people. And chronic conditions, as we've heard so far, are really now starting to define the challenge of our modern healthcare system. And diabetes, a condition that affects, nearly 1.7 million people living in Ontario today, projected to be at about 2.3 by 2034, is that gateway. I know Kim mentioned she's, a person living with diabetes. I also, live with diabetes, was diagnosed with it in 2016. And so if we want to stem this tide of this chronic illness, we really need to start where it so often begins, and that's with diabetes. I think Ontario's health system was built in the 1960s to handle acute emergencies, not to support people living with lifelong conditions that require daily management and coordinated care. But today, for example, I think even Connie mentioned this, nearly three-quarters of seniors live with at least one chronic condition. And while we've made enormous strides in helping people survive chronic illnesses, I think we've done far less to help them live well with it. And so you mentioned Motion 45, unanimously passed by the Ontario legislature in 2023. It recognized this need, and it called on the government to develop a provincial chronic disease framework, starting with diabetes. But for nearly 2 years now, I think, could say progress has stalled, and yet the need for that action has only grown. And that's why I think it was so critical for Life Sciences Ontario, with Diabetes Canada and the Health Charities Coalition of Canada, to come together. And what we've laid out, I think, is a clear and pragmatic set of recommendations that is starting to focus on diabetes, but then we can actually move to other conditions as well once we start moving forward on this one. And these aren't theoretical proposals. I think they're truly actionable, immediate steps that will improve outcomes, reduce costs, and offer a scalable foundation for a broader chronic condition strategy. And I think some of those, there are highlights in here that I think really talk about the urgent action that needs to happen. First, I think talking about establishing or enhancing a diabetes management team within Ontario Health. A quick shout out to Vicky Lee, who I believe is on this call. They do a great job, and I think if we can enhance the team, help coordinate efforts across the system, align with community partners, and crucially, really start to center the voices, I think, of Indigenous peoples and other groups that are disproportionately affected by diabetes, is a very good starting point. I think expanding diabetes screening in pharmacies, making it easier to catch and treat the condition early, when interventions are most effective. Because, as a guy who is hoping to make my flight to Sudbury, where I'm based, when you start to get to, further north, it is very difficult to try and find, doctors and endos who can do these early interventions. That's why I think diabetes screening in pharmacies is something that would be welcomed. Also, rolling out targeted awareness and education campaigns. I don't think not just for the general public, but for healthcare professionals. So they have the tools and knowledge, and we have our clinical practice guidelines at Diabetes Canada, and those really support patients effectively. promote community-driven initiatives like the Cities for Better Health that is being done in Mississauga, so we can shift away from shift that focus from managing the illness to building healthier communities, healthier environments. And let's not forget, we have administrative burdens right now in Ontario, especially for people who are living with type 1 diabetes, who must, navigate redundant paperwork procedures for lifelong conditions. We really could help reduce some of that red tape. So, when we look at all of the common sense kind of steps that I think we've been talking about, we really will be able to build a foundation for a healthcare system that will be ready to meet the demands of every generation. And I think Ontario really has this opportunity to lead, not just with words, but with action. And I think I was stealing those words too from Russell Williams, who is our retired SVP, but is also an LSO board member, who I also think is on this call, who should get a lot of credit for the work that we've done on this. So, all in all, I think the path forward here is clear. We now need that courage, the coordination, and commitment to walk it. And I think that all starts with addressing diabetes as this condition. And with that, I think I'll hand it back to you, Jason, and look forward to the dialogue.
Thanks so much, Glenn. And I know it's a bit of an effort trying to join us from while you're stranded at the airport. So appreciate all your efforts there. And thank you for calling out Russell Williams as well. Definitely a special thank you to Russell for really initiating this work and pulling these groups together. Absolutely phenomenal job. And we always count ourselves very lucky to have him as part of our organization as well. Um, there were a couple comments and requests for links to the report. So I'm going to ask my staff, maybe Faith or Sharanya, whoever has it at their fingertips, if they wouldn't mind putting it in the chat, so that people online can have a direct link to the chronic disease report. Next, we're going over to Dr. Bhatia.
Great. Well, thanks so much, Jason. Thank you to LSO for having me on this, this wonderful panel, and obviously, congratulations on the report, because it's certainly something that we at Ontario Health, take quite seriously in terms of looking at the recommendations. And much of I think what's been said, I think really resonates well with not just our current thinking at Ontario Health, but both future and frankly a lot of the work that we've done within the legacy agencies that make up Ontario Health. So as many of you know, we've had a long history of addressing chronic disease prevention and management, including diabetes. So some of our legacy agencies initially created some of the early clinical guidance and guideline documents for diabetes, like type 1 diabetes, diabetes in pregnancy, pre-diabetes, and type 2. We've supported diabetes education programs, like 150 adult diabetes education programs across the province, aren't just in hospitals, but in primary care, focused on education and management, 35 pediatric diabetes education programs, and 6 centers for complex diabetes care. I think, one of the things I think that is really poignant in the report is the need to have integrated care. And I think, many of the comments about how are we aligning our system to be less acute care focused and more integrated between the community as well as acute care and particularly primary care is quite, I think is quite, timely. I would say, some of the successes, and again, there's lots of challenges I think that we can speak to as you have, but I think some of the opportunities has sort of been mentioned, and I would say some early successes has been in some of the work that we've done around integrated clinical pathways. And so, as many of you know, our Ontario Health teams have been focused, which includes hospitals, community providers, primary care, have been working on trying to redesign care locally around, 3 different types of diseases, many, chronic diseases that have very significant burdens of illness. Heart failure, which has a significant diabetes component, COPD, as well as lower limb amputation. As many of you know, Ontario is one of the worst jurisdictions in the OECD, in terms of amputations for lower limb much of those can be prevented through better wound management, better diabetes care. What we've started to do is again bring these groups of providers together, and currently we have 25 distinctive, programs, chronic disease management programs like these running in the province, where we look at how do you fund these programs more in totality? How do you ensure that you can support, teamwork across the silos of our healthcare system to achieve better value and outcomes? And again, how do you ensure that you're measuring the impact of these integrated efforts, particularly from a patient perspective? So we've in all of these programs we've supported again the integration of primary care, hospital and community care, as well as home care. Ensured that there are clinical services, like for example in lower limb preservation, ensured access to vascular surgery services, but also foot and wound care and chiropody, as well as diabetes management services. And what we've seen in the early results have been quite remarkable. We've actually seen significant reductions in lower limb amputations, reductions in hospitalizations for heart failure and COPD at a population level. Now, numbers are small, and more work to do, but I think incredibly promising as a way to begin to, and as an approach that again begins us to all work together rather than working in silos to coordinate care to ensure the patient gets the care in the right place and avoids some of the significant complications. And we're going to need to do more of this because, as and as you've said, our rates of diabetes are significantly increasing, as are our rates of multimorbidity. So I don't think diabetes or any of these diseases comes along, as a solo companion. They often have multiple, bedfellows, and so as a consequence, how do we ensure that we're thinking about a person as a whole person and looking at the multimorbidity that they have and ensuring again strong connection to primary care, because that's where a lot of the front door to our healthcare system for the majority of people is still located. So I think there's lots of opportunity. I think that again, I think the findings of this report will be very something our team will study very closely and see for opportunities for alignment. And we're excited about the work ahead.
Thank you so much, Dr. Batche, and a special shout out to your team at Ontario Health. Every time that we've reached out to anyone at Ontario Health, they've been responsive, they've been engaging and collaborative. So it's been really, really wonderful, and that partnership and the insights that they have provided has helped shape this report and these recommendations as well. And so again, back to this collaboration, it really is going to take everyone from the patient perspective, from the industry perspective, from the research perspective, from frontline healthcares to government, right through working together to really move the needle for chronic disease patients. That was a really good segue, though, your last few comments to my first question, which is going to go to Glenn. When Motion 45 was announced, it was a call for chronic disease strategy, but specifically starting with diabetes. And so, diabetes is considered that gateway condition in the context of chronic disease. Um, and so, why is that, Glenn? And how can focusing on it catalyze broader systemic reforms in Ontario's healthcare approach?
Yeah, thanks, Jason. It was exciting to see Motion 45 present and then pass unanimously through the legislature at Queen's Park. And, as a former elected official myself, I know how difficult that can be to get something to pass unanimously. So it was exciting. And, when you're looking at, as you said, diabetes being considered that gateway condition, I do think it's because it often opens the door to a cascade of, I think, other serious chronic conditions. It rarely is isolated, right? It's 30% of strokes. Diabetes is a contributing factor in that. 40% of heart attacks. 50% of kidney failures and 70% of non-traumatic amputations in Ontario. And I know the doctor said, that we unfortunately have, the title of, the highest numbers. And so, those are the concerning things. And so when diabetes takes hold, it really doesn't just complicate life for individuals. It can trigger a domino effect, I think, across the entire healthcare system. So focusing on diabetes, I think, provides an ideal entry point for that broader systemic reform because it touches on every part of healthcare, primary care, mental health, pharmacy, something that has been mentioned a couple of times now, community supports, technology, education. So I think it reveals those structural gaps in how we currently deliver care, especially for conditions that require constant management and not one-time treatment. So, if you start to think of examples like simple interventions like diabetes screening in pharmacies, it can increase early diagnosis and reduce those complications down the line. So streamlining even some of the administrative processes that I talked about for type 1 diabetes and getting more endos spending, the time talking about the importance of the care versus the outdated systems that I think can really both waste the provider's time and the patient's time. Because again, we've talked about these numbers. It's so prevalent. 1.7 million Ontarians today and climbing. And so I think investments made here can have those wide-reaching impacts. And I think diabetes is that pressure point where focused, practical reform can generate the ripples across the system. And so, I don't think starting with diabetes, starting with it, I think, is medically sound and it's strategically smart. And so that would allow us to modernize our care delivery, reduce system strain, and I think lay the groundwork, lay that foundation for truly a 21st century approach to chronic condition management in Ontario.
Thanks, Glenn. I did have a question come in about the recording of this session, and we are recording this session, and we will share a link to that recording with the attendees. So for those of you, if you're having trouble with connectivity, and we will make sure that you get the full content available to you post this session. My next question is to Dr. Bhatia, and I've heard more than one person lament that Ontario has a sick care system instead of a healthcare system. And I think, contextually, what they're speaking to is that our design really was centered around acute care. And what we're talking about here are structural changes that are necessary to adapt it to prevention and management of chronic diseases. So can you speak to, what it's going to take to go through that transition?
I think um, it's certainly not an easy process, and I wouldn't say Ontario is alone in that. I would say that's pretty much the Western world has sort of focused its attention and spending on hospitals. So this is a discussion that you could easily have in Helsinki or in Madrid, and you could have in Toronto. So I would say, but I would say the one thing that I think is clear is that if every high performing healthcare system in the world has and puts an emphasis on primary care as its foundational center. That's not something that we've done in Ontario until very, very recently. And I would say, what we have is we've had thousands of sort of points of light on, in terms of independent offices in primary care, less of an emphasis on team-based primary care. Only 30% of Ontarians sit in teams. And I mean, one of the major political challenges that I think you've heard is that, the lack of access to primary care, and there's multifactorial reasons for that. So, one of the reasons I'm quite heartened is, with the Premier of Ontario appointing Dr. Jane Philpott as the lead for primary care in the province, and the significant investments that have been announced as a consequence of that. I'm hoping that what we see and what we're aiming for is, one, connecting more than 2 million people to care, but also increasing the proportion of Ontarians that have access to team-based primary care. And as you know, if you're going to manage chronic diseases, you need to manage chronic diseases in a team. Not one person can do it. And that's going to include folks that do diabetes education and prevention, is going to include nurses, it's going to include dietitians, it's going to include a number of other folks, mental health workers and others. And so I think that's sort of the infrastructure piece that's required. Then we have to start thinking about all of the programming and the connectivity between, an organized team-based primary care system, community specialty care and community services, and yes, the hospitals, because the hospitals also have evolved to not just be sort of acute care-based entities, but actually do deliver quite a bit of subspecialized, ambulatory care. And, that's where, frankly, a lot of our specialists in the province of Ontario and specialized services live. The challenge, as many of you know, is it is difficult at times, being a primary care doctor in the community, to connect into those services and have information bidirectionally flow between those two silos in a way that allows real-time management of patients. And so then there's a component of, well, how do we build both an information system as well as a performance management system that ensures that, if I'm a patient with diabetes, my primary care doctor may be my point of contact, but I have connections to a variety of other community services and specialists that all know what's going on, with me and can all work together to manage my condition. And so I think it is really chronic diseases is sort of the rallying cry, so to speak, for the need for us to create true investment in a structured way in community, particularly creating, a medical neighborhood, medical home, team-based primary care, whatever term you want to use, but basically ensuring that people have a team of professionals that support them, that have all of the right information and tools and connections to the services that allow them to get the care when they need it, how they need it, and then to be held accountable so that we can ensure that people who have high levels of hemoglobin A1C get that appropriately managed so they live as long and healthy as possible.
Thanks, Dr. Bhatia. And I love having you as a panelist because you're setting up my next questions perfectly. So that concept of collaboration that you just spoke to, Kim, I want to turn to you and ask you this question about, how can partnerships with patient organizations and health professional groups advance education on prevention as well as fostering a more proactive healthcare culture?
Thanks for the question, Jason. I think that collaboration is fundamental and foundational. Part of the seed of Motion 45 was planted, I think, by the creation of what became the National Diabetes Framework. That work began under the leadership of Russell Williams at Diabetes Canada in 2017, and we were inspired by a 90-90-90 framework in HIV/AIDS to say, what could we do to really reduce the burden of diabetes in Ontario and in Canada? And that question gave birth to a collaboration among 120 stakeholders from all sectors that support the life sciences ecosystem. I don't believe that framework, which became law in 2021, could have been achieved without all 120 stakeholders at the table. We needed to have the patient perspective. We had more than 40 patients at the table coming up with the recommendations that went into the National Diabetes Framework. We also had academia, we had healthcare providers, we had industry, because we can't do it in isolation. We must work together in order to achieve this. The taxpayer can't bear all the cost. Industry can mobilize resources quickly and efficiently and complement what governments are doing. We've talked a little bit about the opportunity in using pharmacies for screening and delivering advice. I couldn't endorse that more fully. We can leverage telehealth more to ease the burden of the health human resource crisis. diabetes is a tremendous use case in that example as well, because more and more people are using diabetes monitoring devices that give us access to lots of data about our health that can be tapped into remotely by healthcare providers who can provide great support without people necessarily having to visit a clinic. And that can address the burden on those in remote and rural communities, etc. And then, as I mentioned, we have to continue to fundamentally involve people with lived and living experience of diabetes and its complications every step of the way. We had more than 40 patient partners involved in creating Diabetes 360 that became the National Diabetes Framework. And that was essential because only those with lived experience can tell us what really gets in the way of screening, care, and health outcomes. It can be easy to sort of blame someone when their A1C or what have you is not where they would like it to be. But living with diabetes day in, day out is extraordinarily difficult. And it's a disease that defies kind of compliance the way that some folks maybe used to think about it. You can do the same things, the right things day in, day out, and not always get the right outcomes. So those with lived experience must be at the table, aligning with other experts from all sectors on which outcomes really matter.
Thanks so much, Kim. And I know that you're coming at this too with your personal experience, and appreciate you sharing those insights. Connie, I want to ask you to build on Kim's comments, and specifically around allied health professionals, because a real focus that we heard from more than one stakeholder that we spoke to as we were building out this project, that our recommendations need to engage allied health professionals, that it can't all be on primary physicians. So, what role can health professionals play in a reimagined chronic disease care model, and how can their involvement be optimized?
Thanks, Jason. And you're right. This was a big portion of our discussion. And when we talked to our patient population, it was really about who are some of the professional groups that are there supporting and providing that evidence-based information on a regular basis. And part of the challenge with this group is often patients or people with lived experience don't have access to this group. They're a hard group to be able to come. It's often you have to pay out of your own pocket to be able to access them. And that sometimes can make it really challenging for patient groups. And so when I'm thinking of our allied health partners, I'm thinking, for example, of the respiratory educators who, may sit down with a person who is experiencing severe asthma and really help them develop an asthma care plan. It may be perhaps the physiotherapist who is working with someone who is either living with arthritis or osteoporosis, and making sure that they understand how can I actually get back into movement and feeling well without experiencing extreme pain, and what does that look like? How can I do that safely? Because as an individual living with a disease, these are things that you're not sure about. And to book time with a primary care provider every time you have one of these questions, sometimes may be really challenging when there may be other providers out there who have answers, who can support you in a really meaningful way. So it's really freeing up some space within, the healthcare system, and giving you really important information in conjunction with. We're not saying we don't want you to work with your primary care provider. That's not the plan, but it's part of that team. And I thought, Dr. Bhatia did a really good job at really talking about really enhancing all the skills of the entire wraparound support system that's there for patients and their families. Another example that comes to mind, and I think both Kim, Glenn, and Dr. Bhatia, you all talked about this, the importance of having dietitians, and having folks that are there to be able to provide great consultation to people who are living with diabetes, kidney disease, folks who are, recovering from a cardiac event, and trying to understand how can I really plan and be able to best live, manage my health as best as possible. All these things have great impacts on people's well-being, not only their physical self, but also their mental health and their well-being. And so it's all of these allied health prevention professionals provide so many additional supports and resources that we really want to make sure that there are great care pathways to be able to get access to so many of these supportive services. So that was one of the core recommendations, to make sure that we're weaving them into our care plans and our overall sort of projections in terms of how can we support people to be well within our system.
Thanks so much, Connie. Dr. Bhatia, you touched on this a little bit, but I'm hoping you can expand. As we're thinking about implementation of strategic initiatives for chronic diseases, how do we ensure that these initiatives also have equitable access to care and address disparities faced by marginalized populations?
It's a really important question, Jason. So I would say first off, organizations have to think about it, actively plan for it, and it has to become part of your ethos. And so at Ontario Health, for example, we have worked with a number of community partners to create and publicly release the Black Health Plan for Ontario, as well as a First Nations, Inuit, Métis, and Urban Indigenous Health Framework. And so that sort of puts a stake in the ground to say this is what we're going to do, and it has targets and actionable, recommendations associated with it. I think the second is really thinking about working with and consulting with and co-designing with members of the community, right? Because what we think matters may not matter to them. And, when it comes to diabetes, we know much higher rates of prevalence in South Asians and Indigenous folks and Black folks. And so if you want solutions, you have to go ask those communities, and it's really important, and work with them. The other thing is data. I think data is critically important. A data-driven approach can help identify high-risk populations, inform when we want to put services, and then individualize risk assessments, right? So we have something called My Cancer IQ, an OH tool that really allows you to look at personalization based on data. And, again, looking at things like race-based data does matter. The last thing I would say is, again, I'll give you an example of where, I think we've done this right, is Ontario recently expanded screening for mammography to the 40 to 49 age range. One of the major questions of consideration was, how do we reach folks in underserved populations, particularly, new immigrants, Indigenous, Black communities, because we know historically that these communities are underscreened for, again, a variety of reasons. And so what we did was put in, again, take a thoughtful sort of a priority approach to thinking about specifically what are the services that we're going to do to ensure that we don't leave anyone behind. And so what that meant was, hiring prevention specialists that have provided, culturally responsive, breast screening conversations to women in the communities that they live, like in CHCs and community groups. And so those conversations have led to increasing screening rates, again, amongst those communities. And so that, again, we're not leaving people behind. So again, I think it is about planning, being intentional, data, and co-design with the community and listening.
At the risk of being a little political here, Dr. Bhatia, I'll say, given the very distinctly different approach that's happening south of the border right now in terms of the treatment of data for particular demographics and equity deserving groups, and your comments that you've just made makes me a little prouder to be a Canadian. So thank you for that. Um, Glenn, how can expanding diabetes screening in pharmacies, along with promoting community-based initiatives like Cities for Better Health that you mentioned before, contribute to more accessible, earlier detection and more effective prevention of diabetes at the population level?
Yeah, thanks for that question, Jason. And just before I dive into that, I apologize for any of the background noise here at the airport. Truly feel like I'm Tom Hanks in the terminal, where I'm got a first name basis with the cleaning crew, asking them to come back in 5 minutes. Anyways, all that being said, I think it is important for us to look at expanding diabetes screening in pharmacies, and it is a strategy that is supported by Diabetes Canada, because it is I think, of one of the most accessible, scalable tools that we have for early diagnosis of type 2 diabetes, which often develops silently over time, really without symptoms. And I mentioned it earlier, pharmacies are embedded in almost every community across Ontario, and including some of those underserved or either northern or rural communities, which often don't have access to multidisciplinary healthcare teams. They're open evenings, they're open weekends, they don't require appointments. And Jason, that's the kind of access that matters. So, by, I think, empowering pharmacists to screen at-risk individuals and equipping them with the tools and training through partnerships and with organizations like Diabetes Canada. I've got great colleagues with great programs. Gina D'Souza is our ED of Healthcare Practitioners Engagement and Education, and Jennifer Puccino is doing our work on knowledge and connection. We really can identify, through this partnerships and through our tools and training that we have at Diabetes Canada and with pharmacies and pharmacists, to identify these people earlier, intervene as quickly as possible with individualized, care and prevention, and then we can start talking about lifestyle and healthy behavior intervention. And that not only improves, I think, the individual outcomes, but it also helps reduce the strain on hospitals, on primary care, and on specialists down the line. But screening is only that one piece. And I know we've talked about community-based initiatives like the Cities for Better Health, and that's where I think that type of programming comes in. It's these programs bringing together municipalities, public health, local businesses, civil society. It creates that environment that makes healthier choices easier, make things, improving walkability, access to fresh food, building local awareness campaigns. Mississauga is leading on this front, and I think it's a model that could and should be replicated across Ontario. And I think we can connect clinical interventions like pharmacy-based screening with local, place-based prevention efforts, and we can stop treating diabetes as a silent disease, and I think start approaching it as the complex condition that it is. So ultimately, I think expanding screening and embedding this early identification and prevention strategies with our neighborhoods, really, we can then, as the title says, we can shift upstream.
Thanks, Glenn. I appreciate that. So we only have 7 minutes left, and there is a couple questions coming in from the audience, but I want to ask two final questions. It really is focused on implementation. So Connie and Kim, I'm going to put you two on the spot. Connie first. What do you think the next steps are required to move from these recommendations to strategy to action, and particularly in terms of funding and policy support? What is missing to catalyze the action?
Well, I think we've already started. There is movement, and I think Motion 45 really determined and demonstrated the willingness to look at this. So the next step is really to rally the troops and to begin developing the implementation aspects. And so part of that, Jason, is really making sure that the voices of all of our partners are included in moving forward. And so the recommendations are there. And what the wonderful part is that these recommendations don't all have to move at the same time. So we can start implementing some of these recommendations and span them out. And so I'm really excited about that. The immediate step is to adopt them and say, okay, well, how are we going to slowly bring some of these recommendations on board and make sense in an overall framework? So it's adopting that framework and then developing the timelines for how we're going to start rolling these out and bringing on partners, including the voice of lived experience within those partners. So the action plan is there. It's just a matter of adopting that framework and developing both the overall framework and the funding to be able to bring that forward. But there's great recommendations there to move forward.
Thank you so much, Connie. And Kim, last question to you. What mechanisms can be put in place to ensure accountability and transparent progress reporting while we're implementing this framework?
I think that accountability is critical. We know in other jurisdictions around the world when they have put in place feedback loops that share the results that they're getting through their diabetes registries or frameworks or strategies, they've been able to achieve better outcomes. And so I would pick up on a point that Dr. Bhatia raised earlier, and that's data. We have so much data that we need to analyze, like pool, analyze, and report out on in order to depict and understand the burden of diabetes in Ontario and make progress. And I think I would underscore everything that the others have said and add, let's not let perfection be the enemy of good. There are things that we can start doing right now that can have a huge difference, some of which we've talked about. And then let's embrace a continuous learning mindset where we can, using that data, sharing it transparently, we can continue to make things better as we go forward. The last point that I would add is that we need to resource these efforts. This isn't going to happen off of the side of people's desks, and it's too important to be relegated to that space. So I would urge all of the relative stakeholders to plan to resource this collaboration so that we can make progress on behalf of people in Ontario.
Thank you. I think we have time to address two quick questions from the audience. The first one came in from Wendy with Migraine Canada talking, and I really want to just sort of broaden this a little bit. We said chronic disease strategy, starting with diabetes as the model, and I think the question is really focused for those other chronic disease areas. What would you say to them in terms of how to move forward, using diabetes as a model? Like, what's the next step for patient advocates and organizations working in other areas beyond diabetes? And Connie, maybe I'll put you on the hot seat on this one because you have a broad group of stakeholders at your organization. So, what do you tell the folks in other areas, other chronic disease areas?
Yeah, and thanks so much for the question, Wendy. And one of the reasons why we came together on this was really looking at how we utilize the experience in diabetes and really lift it up to apply to other chronic diseases. And that's why when you look at the recommendations we really felt would stand across many chronic diseases. So it's really, as I said, some of those recommendations are things such as how can we best utilize technology? How can we ensure that the data is being recorded and that we have consistency in the data and that we're utilizing it to the maximum efficiency that we can? It was things such as where will prevention live and how can we make sure that people have access to to prevention and screening? So it was things that we really felt applied not only to the diabetes space, but really across other chronic diseases that would really elevate and support people who are living with chronic diseases. So I really urge you to take a look at some of those recommendations. And when we developed the paper, we really looked at several different chronic diseases, and the recommendations were pulled from different groups as well. So there was a lot of synergy in terms of what individual chronic disease groups were recommending. And this was a sort of a marriage of many of those recommendations across many different chronic disease groups. But thanks for the question. It's a really important one.
Thanks, Connie. I see we're at 12:59, so I am going to wrap up. I want to say thank you to the panelists for all of your insights and commitment to improving prevention and care for chronic disease in Ontario. Thank you to everyone who has joined us virtually and accepted the invitation to go upstream and to help Ontario move towards a healthier, more sustainable future. On the screen, you'll see the QR code. There's also a link in the chat to the paper. We'd encourage you all to take a look, some time and review that. Love to hear from you, your thoughts, comments. We are recording this session. We will make it available to the participants. Thank you once again. Really appreciate all of your help and your commitment and determination and collaboration going forward on the next steps. This is really just the beginning. We need everybody working together to move this paper, the recommendations into implementation. Thank you very much. I hope you have a great afternoon.